Nau mai, hara mai, tauti mai, e te whānau. Good evening and a very warm welcome to everybody. I am Nicola Bertossi. I'm General Manager at Multiple Sclerosis Auckland. It's my pleasure to welcome you here tonight. I'm also joined by my colleague Luminita Apostle, who's our Senior Community Advisor, and I'll introduce our presenters in a minute. So the format of tonight's session will be a presentation, in fact, two presentations, and if you could leave your questions till after those presentations, then that would be ideal. If you have questions, please just type them into the chat box, and we'll endeavour to get to all of them. Just if they could be of a general nature, so they'll apply to other people in tonight's webinar, that would be fabulous. So without further ado, I'd love to introduce to you our really special presenters tonight. We are joined by Dr. Alchin. He is a specialist pain management physician, retired from clinical practice, but still here with us tonight. And he was at the Pain Management Centre at Burwood Hospital in Christchurch, where he worked as a consultant since 1998. He still teaches in the Department of Orthopaedic Surgery and Musculoskeletal Medicine at the University of Otago in Christchurch. Our second speaker tonight, thank you so much, Dr. Alchin. Our second speaker tonight is Mr. Simon Goss, also beaming in from Christchurch. He's worked as a clinical psychologist at the Burwood Pain Management Centre for the last 6 years. He's an active member of the New Zealand Pain Society and has presented at Pain Society conferences, as well as education conferences for a wide range of health professions and students. Alongside his usual clinical work, Simon has assisted with the design and implementation of an online pain education course, which is now provided to most patients referred to the Burwood Pain Management Centre. Other than persistent pain, his clinical interests include functional neurological disorder, concussion, and the influence of psychological factors on the experience of illness and disability. So thank you. Thank you so much. Wonderful accolades to share with everybody. So without further ado, unless there's anything else, Luminita?
No, that's amazing. Thank you. Thank you to our guest.
I will hand over to, I think Dr. Alchin is going to speak first.
Yes.
Okay, over to you.
Okay, so can we have these slides there? So look, welcome everyone. I'm a pain medicine specialist. I'm not an MS specialist. I'm not a neurologist. I'm sure there's people online here who know more about MS than I do. So my field is pain. So don't ask me questions about MS, because as I said, you'll know more than I do about that. So I've got a number of slides here to go through, and please keep an open mind. I'm going to say things that may surprise you. You'll have access to these slides later. You can go over it again. And I've documented where I've got the information I'm putting down here. What we're going to talk about will come as a surprise to some of you, and maybe some of you will disbelieve it. But just bear with me and let me present the evidence that's here. Okay, next slide, please. Okay, so now the first two slides, this one and the next one, I'm not going to go over that. This is to jog my memory. You people know all this better than I do about what MS is and so on. Next slide too, please. And can you slip over that slide also? Okay, so now we come on to field of pain in MS. So pain is a common problem in people with MS. Headache affects about 40 odd% of people with MS, and migraine needs to be treated as you'd normally treat migraine in anyone else. There's a specific form of pain that goes with MS called central neuropathic pain that can be felt in the arms or the legs. That's about 1 in 4 people with MS experience that. In other words, 3 out of 4 don't. We'll get on and talk a bit more about that pain in a few slides. Then there's back pain. Anyone can get back pain. It's very common, but people with MS can also get back pain. It's not due to their MS, but it's just something through which humans are likely to be afflicted, like a tonsillitis or appendicitis. Then you get painful muscle spasms. That's more specific to MS. That may need specific treatment with intrathecal baclofen pumps. And then there's trigeminal neuralgia, which is a very brief stabbing facial pain, one half of your face or one side of your face. It affects about 3.8, nearly 4%, nearly 1 in 25 people with MS get trigeminal neuralgia. Now, that's far more common than you find in the general population. And also, the best treatment for trigeminal neuralgia is a drug called carbamazepine, which is used for epilepsy. That is not as effective for people with MS and trigeminal neuralgia. So that's one of the problems. So trigeminal neuralgia in people with MS is both more common and it's less likely to respond to the most effective treatment. Okay, so high prevalence of chronic pain, point prevalence at any time. In other words, if you ask people with MS at this moment, do you have pain of any sort? 50% approximately will say yes. Pain in the last month, 75%. Even if they don't have it now, will recall having pain in the last month. And for a significant minority of people, pain is one of their most severe symptoms. And we can all understand that. Pain also results in worse sleep, fatigue, anxiety, and depression. Okay, next slide, please. Okay, so now we come on. So the first thing is, so not all pain in people with MS is caused by their MS. Okay, so people with MS can get other forms of pain, migraines, low back pain, trigeminal neuralgia. But the specific form of pain in multiple sclerosis is called central neuropathic pain. Now, neuropathic pain, that's the NP I've got there, is pain caused by a problem, a disease or a lesion in a part of the nervous system. Okay, it's an identifiable lesion. You can see it on the MRI scan. You can examine someone and find out they've got a neurological deficit related to that particular part of the central nervous system. Now, neuropathic pain is one of two sorts. If it affects the central nervous system, in other words, the brain or the spinal cord, it's called central neuropathic pain. And that is what MS-related central neuropathic pain is an example of that. If it affects the peripheral nervous system, in other words, the nerves running from the spinal cord or from the brain out to the rest of the body, it's called peripheral neuropathy, peripheral painful neuropathy, for example, with diabetes. Now, we're going to focus today on talking about the specific central neuropathic pain of multiple sclerosis. But the comments I'm going to make apply often to other types of pain. Okay, next slide, please. Okay, so now, this is from a review published 8 years ago now, but it's still one of the most recent and best reviews of central neuropathic pain syndromes. Now, we've mentioned multiple sclerosis, central neuropathic pain. There are two other forms of central neuropathic pain which are quite common. One is if you had a stroke and it affects your brain, that's a post-stroke central, in other words, after a stroke, central neuropathic pain. And another form is if you damage your spinal cord, like the spinal unit at Burwood Hospital. People who've damaged their spinal cord can have spinal cord injury pain. So multiple sclerosis, brain having a stroke, or damage to the spinal cord from an injury. These are the three most common forms of central neuropathic pain. In other words, pain caused by damage to the central nervous system. So this review, published 8 years ago, considers those three forms of central neuropathic pain. Now, I've got down here some statements from that review, which I think are worth commenting on. So first of all, the treatment of central neuropathic pain is very challenging. As a rule, pain resolution is unlikely. Now, I've got to warn you here, one of the problems with medical journalism, medical writing, is its understatement. I would not say that. I would agree that central neuropathic pain is challenging, but I wouldn't say, as a rule, pain resolution is unlikely. I would say, as a rule, pain reduction is unlikely and resolution is extremely uncommon. So that's an understatement. That statement there does not state how bad the situation is. Why is that? Well, several reasons, but one reason is a limited number of high-quality randomized controlled trials. Again, gross understatement, as we'll see in the next few slides. I'm aware of a grand total of one good randomized trial which found a medication that was effective for MS-related central neuropathic pain. Now, that's not a limited number. That's a desert of adequate studies. So what do we do in an absence of specific data for MS-related central neuropathic pain? Well, the next bullet point goes on to say that we extrapolate data from the rare controlled trial of one other central pain state to guide the treatment of another central pain disorder. So in other words, if we've got good evidence, there's a drug treatment that works for, say, chronic post-stroke pain, we may try it for MS-related pain because they're both pain case states caused by damage to the brain. But it still leaves major gaps in the treatment algorithms for central neuropathic pain. So what do we do then? Well, we then go to guidelines on general neuropathic pain, including primarily peripheral neuropathic pain. And in fact, the guidelines for the medical treatment of neuropathic pain are based almost entirely on two forms of peripheral neuropathic pain, which is painful diabetic neuropathy and pain related to having had shingles, what we call post-herpetic neuralgia. So when you look at guidelines, which we'll do in a minute, on the treatment of neuropathic pain, they're almost always based on studies of those two conditions. And we extrapolate from that to say, well, it works in diabetes. Maybe it'll work in this form of pain. In other words, we're making guesses there. Now, the next problem is, having talked about the lack of studies to guide treatment, the next problem is that the next second last bullet point on this page is all pharmacological treatments have potential adverse effects, which further compounds the associated physical, cognitive, and/or language complications from the original central nervous system problem, in our case, MS. What's that saying? Well, what that's saying is that if pain is caused by damage to the central nervous system, it's a nerve damage, any drug that has any potential to work on pain caused by that is going to be a drug that works on the central nervous system. It's not going to be a drug that works on if you stub your toe, if you've got a broken bone, or if you've got appendicitis. So in other words, drugs that work on damaged tissues out in the body, like bones and skin and muscles, like paracetamol, Panadol, anti-inflammatories like Voltaren, morphine, other opiates, they will not work on MS-related pain or any other central pain states, because these are pains caused by not damaged tissues, but damaged brains and nerves and spinal cord. And if any drug can affect the central nervous system, it could also further compound all the problems that people with MS are already dealing with, like central nervous system problems, fatigue, cognitive impairment, maybe mood disorders, things like that. And now we're giving a medication that's going to worsen those things, okay? The next problem here, the final bullet, is there are drug interactions. In other words, multiple drugs, polypharmacy just means lots of drugs, can further complicate the central neuropathic pain drug choices. Okay, next, in other words, this is a difficult situation for all those reasons mentioned there. Next slide, thanks. Okay, so this same review goes on to discuss what is the evidence for these three central neuropathic pain states. So first of all, duloxetine. That's a form of antidepressant, which is, I think, no longer available in New Zealand. But one study, a grand total of one study, found it was effective for MS-related central neuropathic pain. That doesn't mean it works in everyone. It means it works in more people than the placebo worked in. That's all it means. And it was an adequate trial. It was a good trial. It's not a magic bullet, but it was effective. It passed muster. It crossed the threshold for being classified as effective. Okay, so we don't have duloxetine in New Zealand anymore. So the next close to that is venlafaxine. It's a drug that is available. Any doctor can prescribe it. It's related to duloxetine. And other conditions for which duloxetine works, venlafaxine also works. In other words, if I was seeing a patient with MS in the clinic, I would like to prescribe duloxetine as a trial. If I can't do that, I would next try venlafaxine. This is this extrapolation I was talking about. Okay. And that's it. That's the only evidence we've got for drugs specifically for MS. However, in other forms of central neuropathic pain, which we may extrapolate on, there's a class of drugs called gabapentinoids, which these are drugs for epilepsy. Now, in post-stroke pain, pregabalin didn't work, but there were 2 trials of pregabalin in spinal cord injury pain that were effective. Now, this is pretty good. So there's 2 trials of pregabalin for pain caused by damage to the spinal cord. And there's the doses, 410 to 460 milligrams daily. So that, in other words, if I was seeing a patient, I would first of all try venlafaxine, then I would try pregabalin. If venlafaxine didn't work, I'd stop that, and I'd then try pregabalin. That's what this evidence is showing. Then there's a drug called lamotrigine. That's another drug which is used for epilepsy. This was effective in chronic, in 2 forms of central neuropathic pain. Pain following strokes and pain following spinal cord injuries. And there's the dosages there. The next one is amitriptyline, another antidepressant, was effective for central post-stroke pain, but it didn't work particularly well for spinal cord injury pain. Okay, so they're the options really. Duloxetine or venlafaxine, pregabalin, lamotrigine, and amitriptyline. So those are the only drugs that I would have available. If I was seeing someone at Burwood with MS-related central neuropathic pain, they're the options I would have. They're the only ones I would even consider trying. Okay, next slide, please. Okay, so what's not on that slide? No, it does not. That review does not mention the effectiveness of any other medications. In other words, it doesn't mention anti-inflammatories, paracetamol, and opioids. And we talked about why. Those medications are useful if you've got damage to the tissues of your body, not your nervous system, broken bone, appendicitis, tonsillitis, middle ear infection, muscle sprain. That's these drugs here that are used for them. But because that's not the cause of pain in MS-related central neuropathic pain, they don't work. And there's no evidence that they work in this pain. It's stupid to even try them. Okay? You wouldn't even try this stuff if you know the diagnosis. There's another class which we've had a rash on in Christchurch of trying, not us personally, but colleagues have tried a drug called permidronate. It doesn't work. There's no evidence that it works. So I just advise you don't use any of these. This is not worth trying. Okay, next slide, please. Now, interestingly, in January this year, a major leading medical journal called The Lancet, they published a 20-page review of multiple sclerosis. And interestingly, the word pain is, I read through it carefully, only mentioned twice. It does not mention anything about pain management and pain treatment in a whole 20-page review of MS. Next slide, please. Now, these are the current guidelines for treating neuropathic pain. As I said, this is for any neuropathic pain, peripheral or central, but it's based on mainly the treatment of 2 forms of peripheral neuropathic pain: pain caused by diabetes, damaging nerves, and pain caused by herpes or shingles, damaging nerves. Now, some of these tablets, in fact, all of these tablets we saw 2 slides ago, slides showing treatments for central neuropathic pain. Tricyclic antidepressants, that's the amitriptyline we mentioned. Gabapentin pregabalin, that's the pregabalin we mentioned. And there's the duloxetine and venlafaxine, that class that we mentioned. Okay, so these are the drugs. This is the evidence for peripheral neuropathic pain, but they also happen to be the ones that you are worth trying for central neuropathic pain caused by MS. Okay, next, and there's the doses there that we mentioned. Okay, now these same neuropathic pain treatment guidelines, they were the recommendations for, but they also made recommendations against. Okay, now the first scandal of the evening, they recommended against using cannabinoids, cannabis, for neuropathic pain. Why? To quote from this review, negative results. They found it doesn't work. Potential misuse. Hello, some people misuse cannabis. I didn't know that. Diversion, selling this stuff. Long-term mental health risks. Okay, so cannabinoids are not recommended in the current treatment guidelines for neuropathic pain. Okay, but we've now entered the rest of the slides I'll be talking about are about cannabinoids, because I'm presuming that's a really hot topic. Okay, so now we come on to, I'm just checking this time here, see how the time is, which I can't see. Anyway, there's now to talk about 5 reviews that were published in, 27 past 7. 5 reviews that were published in 2018. The first 2 are about general cannabinoids for pain, not specifically MS. And the first one of these was what they call a Cochrane review. Now, I won't go into it, but Cochrane review are really high quality reviews. They're very stringent. They're very cautious, very conservative. If they say that something works, it bloody well works. If they say it doesn't work, it means that there's not enough evidence to put their hand on their heart and say, this stuff really works, okay? So it's a high threshold, a high bar to get over, to get into there. So they reviewed in 2018 the evidence that cannabis-based medicines work for nerve damage pain. Now, what they found, here we go, so just bear with me, to get 50% or more pain relief, in other words, pain before you start the cannabis or the placebo, and pain after you've been on it, if that reduces by 50%, that happens in 21% of people on cannabis, randomized to cannabis. They don't know whether they take the cannabis or the placebo. That sounds good, 1 in 5, doesn't it? 1 in 5 get 50% pain reduction. But wait a minute, placebo, 17% get the same more than 50% pain reduction with the placebo. In other words, most of the pain reduction from the cannabinoids, all bar 4%, was the placebo effect. Now, for 30% pain relief, in other words, not as much pain relief, 39% of those on cannabis, randomized, blinded to whether they're on cannabis or placebo, 39% reported a 30% or more pain reduction, but 33% on the placebo. So in other words, 6% only of people got a 30% or more pain reduction caused by the cannabinoids. In other words, it's a little bit effective, but it's weak. It's really, really pitiful. This is a failure. Okay, now the next thing they found is that cannabinoids increase nervous system adverse effects. That's a surprise, isn't it? Cannabis can affect your central nervous system. 61% of people on the cannabinoids reported side effects. 29% of people on placebo reported side effects. In other words, cannabinoids are more likely to cause side effects than beneficial effects. Psychiatric disorders were reported by 17% in those using the cannabis-based medicines versus only 5% on placebo. This study concluded, quote, the potential benefits of cannabis-based medicine in chronic neuropathic pain might be outweighed by their potential harms. Again, classic understatement you find in medical literature, might be outweighed. I mean, talk about an understatement. Next slide, please. Okay, we got on to the next slide. So here we go. So the next study was also published in 2018. This wasn't just about neuropathic pain. This was about all sorts of pain. This was a really thoroughly done study commissioned by the Australian federal government of 2 universities, University of New South Wales, University of Queensland. In other words, this weren't drug companies. This was and published in the world's leading pain journal called Pain in October 2018. Now, even though they looked at all sorts of pain, most of the studies they had were actually 48 studies of neuropathic pain. There were 91 publications altogether. okay? 48 of those were on neuropathic pain and another 13 on MS-related pain. So in other words, 61 of the 91 publications either looked at MS-related pain or at neuropathic pain in general. So there's a body of evidence here on neuropathic pain in general and MS pain in particular. So what do they find? Next slide, please. So this is again the headline result. To get a 30% reduction in pain on those randomized to cannabis, 29% of those randomized to cannabinoids got a 30% reduction in pain, not a 50%, not abolition of pain, not a halving of their pain, but a 30% reduction in pain occurred in 29% of those randomized to cannabinoids. But 30% pain reduction was achieved by 26% of those who were unknowingly randomized to the placebo. In other words, again, most of the analgesic effect, most of the pain reduction was not due to the cannabis, but was due to the placebo effect. So how many patients did you have to treat with cannabis to get one patient to have a 30%, not a 50%, not an abolition, but only a miserable 30% reduction of the pain? 24. You got to pick 24 patients with cannabis to get one patient to have a 30% pain reduction. Okay. Now, forget a 50% pain reduction, 18% of those on cannabis, but got it, but 14% of those on placebo. This was not significant difference. So in other words, it's like the same as the last review we looked at. This is trivial. This is not of any real significance. It's not a useful medication. Next slide, thanks. And this is really fun if you look at this. So this slide looks at adverse effects. Okay, AE stands for adverse effects. So 81% of those randomized to cannabinoids reported adverse effects. 66% of those randomized to placebo reported adverse effects. Hang on, what are we saying? We're saying 2/3 of people given an inactive drug reported side effects to an inactive drug, which shows, again, the strength of the placebo or the mind in interpreting pain and response to medications. Now, the cannabinoids versus placebo, they had no significant effect on physical functioning. In other words, people didn't function better on cannabinoids than on placebo. There was low quality evidence, in other words, not strong evidence, but low quality evidence for some improvement of sleep and global impression of change. Now, this review concluded, this is a quote, the evidence for the effectiveness of cannabinoids in chronic non-cancer pain is limited. And finally, quote, it appears unlikely that cannabinoids are highly effective medicines for chronic non-cancer pain. Again, understatement. They don't bloody well work. Okay, next slide. This is the same review. They note, which we've just noted, that these findings are largely consistent with the recent Cochrane review of cannabinoids for neuropathic pain, which we looked at about 3 slides ago, indicating these medicines are unlikely to be effective for the treatment of pain. But most of the higher quality randomized trial evidence was for neuropathic pain and MS-related pain. So the conclusion from that study actually relate to you people. They relate to nabiximols, in other words, Sativex, for neuropathic pain or MS-related pain. Next slide, thanks. Now, here we come to, as a result of those 3 studies, those 2 reviews published in 2018. In October 2018, there were these 4 authoritative organisations in the UK released statements, separate statements, but they all agreed. The British Pain Society, the National Health Service, the Faculty of Pain Medicine of the Royal College of Anaesthetists, that's the body of pain medicine specialists in the UK, and the Royal College of Physicians, an extremely eminent body. Now, these group all agreed that the evidence was not there yet for the routine use of cannabinoids in clinical practice. There's a lack of effective pharmaceuticals for chronic pain, so we need better and more robust studies on the potential of cannabinoids in chronic pain. They also looked at clinical use should be for pharmaceutical-grade cannabinoids. No one in their right mind is recommending that people smoke pot for neuropathic pain or MS-related pain. If the evidence does accrue for the safety and efficacy of cannabinoids, we need to expedite its availability. But in the absence of effective treatment, we need an interdisciplinary biopsychosocial approach to the management of chronic pain, rather than trying to rely on a purely biomedical approach. Next slide, thanks. Now we come to three, and I might skip through these, but these are three specific slides. I'm sorry, three reviews, all published in 2018, but specifically on cannabinoids for MS pain. And you can go back and look at the data later if you like, but they all basically come to the same conclusion. There's some slight evidence for these medications for MS-related central neuropathic pain. Okay, so slip over the next slide. And then the next slide. Okay, so all, as I said, if we just look at the final two conclusions there, the final one of those reviews in October 2018 concluded cannabinoids led to mild reduction in subjective outcomes, in other words, what people reported feeling, a mild reduction, but this was of uncertain clinical significance. In other words, we don't know how relevant this is, okay? The effect was so small that we don't know if it's actually worthwhile in a particular patient. Now, an editorial commented on that review, quote, while the pooled estimates, in other words, all the studies pooled together and considered as a body, provide a high-level assessment of statistical significance, clinical significance is less apparent. The extent to which patients with MS experience meaningful changes in symptoms is not clear. This was a methodologically sound analysis, but that does not overcome the limitation of the weak trials that were included. Okay, next slide, thanks. So because of these results in 2019, now that's the top line, FFPMANZCA, says the Faculty of Pain Medicine, Australia and New Zealand College of Anaesthetists. That's the body of specialist pain medicine physicians in Australia, New Zealand, Southeast Asia. In 2019, they released a statement saying there's not enough evidence to use cannabinoids for chronic pain clinically, should only be used by doctors if it's part of a registered clinical trial. Okay, next slide. That's the same thing at the present, same statement from the Faculty of Pain Medicine. At the present time, the scientific evidence for the efficacy of cannabinoids in the management of people with chronic non-cancer pain is insufficient to justify the endorsement of their clinical use. Okay, and next slide. And in 2021, Faculty of Pain Medicine released another statement which urged doctors not to prescribe medicinal cannabis for patients with chronic non-cancer pain unless the treatment was part of a registered clinical trial. The Faculty of Pain Medicine said that we need more clinical evidence before we expose patients to a drug which may not be effective and may cause adverse effects. Okay, next slide, thanks. Now, I don't know how we're going for time. Okay. In later that year, July 2020, now there's one, the International Association for the Study of Pain, that's the IASP, they spent several years reviewing all the published studies on cannabinoids, cannabis for pain, specifically for pain. And this was published in a thick book in July 2021. It was a supplement to the journal Pain. Now, what they've got there, the second bullet point, all trials were judged to be of unclear or high risk of bias, and resulting evidence was low or very low quality in people with any type of pain, including MS. The task force did not find any moderate or high quality evidence. Now, I've highlighted and underlined the next quote from this big, thick book. No included study examined cannabidiol. What that's saying is that when this review was published in mid-2021, they were not aware of any published study of cannabidiol, CBD, for chronic pain. I want you to think about that for a minute, because we're being sold this by all sorts of people who say this stuff is the bee's knees for chronic pain, and yet they couldn't find even one single trial. So next slide, please. And I think this is the last slide I've got. Now, there's an update on that, just published this month. So this is hot off the press. Within the last week, this article has been published. So just remind us at the top there, the last study published in July 2021 said no study examined cannabidiol. But this month, in the Journal of Pain, another review looked at published studies since then, from 2020 to September 2023. Now they found there have been 16 randomized double-blind trials of cannabidiol versus placebo. And this is a total of 917 patients who are randomized either to CBD or to placebo. Now, many different pain states, different routes of administration, different doses, and very different durations of treatment. Now, the next slide hasn't made it onto this, but I can tell you what they found of the 16 studies. Oh, there we go. There we go. Thank you. Oh, sorry, I didn't ask for the next slide. That's my fault. Thank you. Thanks, Luminita. There we go. So the results of this thing, of this review of the studies published until September last year, quote, CBD, cannabidiol, produced little or no pain relief, with no statistical or clinically significant difference between CBD and placebo. With one exception, there was one randomized trial that did find a difference. Now, we'll look at that in a minute. But 15 of the 16 randomized trials were negative. They did not find CBD to be any better than placebo. Now, the one study that did find some effect is this. There are 18 patients. Now, that's a very small trial. 18 patients with symptomatic thumb-base joint OA. That's pain of that joint. How see if I can get it? Pain of that joint there, which is very common in the elderly. What they found, topical CBD. This isn't swallowing the stuff. This is not smoking the stuff. This is rubbing it on the skin. Okay, I've got a sore joint there. We'll rub some CBD oil onto that joint. That's what we're talking about. 9 people randomized to rubbing the CBD oil on, 9 people randomized to rubbing a placebo ointment on with no CBD in it. And they found that, and this is astonishing, and I don't believe a word of this. This is too good to be true. They found that everyone treated with the CBD oil improved majorly. None of those treated with the placebo improved at all. That's simply unbelievable. That does not happen in clinical trials. So that's the one exception to the 16 trials that found no effect of CBD on chronic pain. And those 15 that didn't find any effect included, I've got it down there, a 4-arm RCT of 114 patients with central neuropathic pain and or spasticity related to either multiple sclerosis or spinal cord injury. In other words, that of all these 16 studies, that's the one that's most relevant to you people. And they found no difference. People randomized to CBD for central neuropathic pain or spasticity did no better than people randomized to placebo. Okay, so they go on to say there should be no excuses for misleading the public, and yet it is likely that the public is being misled and possibly placed in harm's way. It is unclear why there is tolerance for the marketing and use of a product without proven benefit, but with risk of harm to a large population of people suffering from debilitating pain. Okay, so we can speculate on why that is. Okay, thanks, Luminita. Sorry for running over. Sorry, Simon. Sorry, everyone.
No. Thank you so much, Dr. Alchin, for the presentation. I just want to let everyone know that the slides are going to be available on MS Auckland website alongside this presentation that's being recorded, because it's been a lot of information and people are a bit, overwhelmed and they want to go back to some slides, but everything's going to be recorded and available. And you mentioned about the CBD trials and the lack of evidence that they improve pain, but you didn't mention the THC levels in these products. This is one question from someone, would that maybe alleviate the pain or?
Thanks, really good question. The reason I focus on CBD,
on the pain levels.
Can you hear me? Am I coming through?
If the THC would be Yeah.
Okay.
Yeah.
The reason I focus on CBD is because that's the one that most people are using. That's the one that's most being touted. Also, it's the one that doesn't have any psychoactive effects, and is not thought to be addictive. The other problem, though, is that Sativex has THC. The problem with THC is it is potentially addictive and it's psychoactive. So there are real issues there, but it's likely, we knew theoretically beforehand, we've known for a decade or so, if any cannabinoid is likely to be useful for pain, it's more likely to be THC, unfortunately. Okay. But in that last trial I spoke about, where there was one trial of central neuropathic pain, they did actually, I said it was a 4-arm trial. One was placebo, one was CBD alone, one was THC alone, and the other arm was CBD plus THC. In that study, they found no effect, not only with CBD, but there was no effect either when you combine THC with CBD. But if you're going to use THC, you've got all sorts of other problems: safety operating machinery, safety driving, all the rest of the stuff. Yep.
Yeah. And let's find out some strategies to manage pain from Simon Goss. Thank you.
Hello, please let me know if you can't hear me. I'm just trying to share my slides, so hopefully that will work out. It should be up now, I think. You might be a little bit disappointed because I'm not going to, unfortunately, be able to provide you a wonderful, comprehensive list of strategies following John's perhaps slightly pessimistic but very well referenced overview of the current pharmaceutical options for the treatment of MS pain. But what I am hoping to do is perhaps give you a little bit of an insight into, look, again, if John is trying to suggest to you, and the benefit of having John here is that if I say anything that is incorrect, John will interrupt me, which is fantastic because people who work in pain like being told that they're wrong about things. So if I say anything too mean about doctors, I promise you he will tell me. But what stood out to me from listening to him is that, one, it's pretty pessimistic when it comes to effective medical treatments. But something I want to point out is that for other forms of chronic pain, it is usually equally pessimistic. There is not kind of a specific thing that makes MS pain much worse than for others. For most people, medication isn't this magical fix, which means that other people like myself end up having work to do. So hopefully I can give you a little bit of an idea around what that other work might be and the kind of role that psychologists and other clinicians might have in helping people with pain, whether they have MS or otherwise. And hopefully that will give you maybe some questions that you can submit about anything related to this stuff, because it's very hard to navigate the world of pain treatment. There is a huge variety of available services to people depending on where they live and depending on capacity. So please ask any questions that you like. So I want to give you maybe some basics around kind of, okay, well, maybe medication isn't this wonderful fix, then what actually is the rest of pain management? What to expect from a service or a provider? Some differences and similarities between how we might go about helping people to manage MS-related pain versus the kind of more broad picture of chronic pain in general, and maybe a very brief summary of the role of psychologists and some of the types of tools and therapies we use. Again, there's a huge amount that I could speak to, so I will take it from you if you have any questions about kind of more specific aspects of any of those things. And a couple of caveats are, I'm not an expert, and I think that it's usually a fairly safe thing to be a little bit skeptical if anyone tells you that they're an expert in pain, because it is a very complex thing. And I'm absolutely not an expert in MS either. So I do see some people who have MS-related pain, but I'm not an expert. This is not all-encompassing. And again, I'll reiterate that actually quality pain management services are really hard to come by a lot of the time. So even if you might know what you should be able to access, sometimes that is really hard to actually find. This is more kind of casual and less research focused. So I'm not going to use lots of citations. And it's actually not that MS specific. And the reason for that is if someone came into the pain service where I work whether they have MS or another neuropathic pain condition or another chronic pain condition, it doesn't really change the core elements of treatment. We don't have really specific treatments for headaches, for back pain, for MS pain, for other pain associated with neuropathic issues. The overall approach tends to be similar regardless of the diagnosis. And like I said, please ask questions. So the thing to reiterate is the importance of this idea of the biopsychosocial model when it comes to pain. And this is something that John mentioned very briefly, and it's something that might be familiar to you. And this is kind of an extension of the factors that contribute to the overall health of a person. So typically and historically, medicine has really been focused on kind of looking for the cause of something and a single factor that you can treat and then fix. It aims to fix illness. Whereas the biopsychosocial model is more something that considers all of these other factors that are more holistic factors that relate to health and doesn't focus on single causes. It assumes that actually there are lots of variable factors that contribute to this overall complex thing called health, and that they span these very different domains. So yes, the things that do happen inside your body and to your tissues, but also aspects of your psychological well-being in terms of your mental health, your emotions, your beliefs, and your social networks. And so how well you are supported and what your kind of social dynamics look like. By including all of these factors, it means we don't miss stuff that is really relevant to how things like pain work, but it also gives us lots of other things that we can try and treat and improve. And so in chronic pain, this is a model which is kind of at the cornerstone of how we think about what we do. We don't just think about the medical stuff because, as John said, actually that's not enough. There is this more broad formulation of things that we know affect pain for anyone, for any human being, but also how pain affects those things in return. So psychological factors like sleep, anxiety, coping skills, depression, thoughts we have, the emotions we have, those are influenced by pain, but they also influence pain back the other way as well. As do social supports and social networks as well. We know that if people have great social supports, they are much more likely to cope with pain easier versus if they don't feel supported and they don't have other people who can help them with the things they're managing. And if you're looking at some of this stuff and thinking, goodness, that seems like a lot of work, that's a pretty broad set of factors that pertain to a lot of the things about who someone is as a person. That seems really complex and a lot of work. And you'd be right. I think that there is this kind of human nature thing where we've all had the experience of a pain at some point in our life that has been there for a bit and then gone away. And when it comes to chronic pain, that kind of belief translates somewhat through society that, well, I've had other pains that should be fixable and go away. Where is the thing that will make this pain go away? And unfortunately, with chronic pain, again, John will jump in and correct me if I'm wrong, but we don't actually have that thing. It doesn't really exist. And so this can influence what people expect when they might be coming to a place like a pain service. My patients will regularly tell me that their expectation was that they would come and see a doctor and the doctor would find the thing for them and then they would be all good and they would leave. But more often what happens is they come into a service, they work with the doctor to clarify a diagnosis and maybe look at some medication trials. And then once that has been done, actually the core part of treatment is learning skills to self-manage their pain. So teaching them skills that kind of span all of these different domains of important factors that go back and forwards with pain. And doing this in a way that means that eventually they don't have to see us. We're not, awful people, but people have much better things to do than come to a hospital to hang out with us. So our eventual aim is that they can do this stuff themselves, that it is effective, and actually they don't need us. So often this involves a lot of work with physiotherapists, occupational therapists, psychologists, social workers, etc. And I'll just, before I go to the next slide again, I'll kind of preface this with something. It's important for me to acknowledge, again, some of these views and beliefs that people might have before they come to a place like a pain service, because truly people think that, look, if they're sending me to see one of these other people, they're kind of just desperate. It's just because nothing else has worked. So now they're forwarding me on to these other people because, you know, they might have some bits and pieces, but it's not that's not really the proper treatment. The medical things are what is going to help me. Which is actually the complete opposite of what both the evidence suggests and the big professional bodies who kind of oversee this stuff suggest. So as John noted before, that little abbreviation up there that says FFPMANZCA, that is the guiding professional body of pain specialist doctors who have qualified as a doctor, but then gone on to specialize in pain medicine, like someone would specialize in orthopedic surgery or gynecology or whatever. So this is from their guiding document about treating people who have chronic pain that is not cancer related, right? Which includes MS pain. And it says here, the first line of therapy, i.e. the thing that has the most evidence and is most likely to be effective, involves engaging the person to help develop pain self-management skills, and that second line therapies include drug treatment, right? Second line. And while this is not a core component of a management plan, it may play some role in helping move towards a successful kind of self-management program, which is that last point. So only ever part of this kind of more broad self-management plan with other clinicians working on these whole person factors. And that is backwards to how quite often care is provided. Usually the emphasis on finding the medical things, and then people feel like, well, if that hasn't worked, I guess fine, I'll have to go see someone else. But the evidence and the science actually says that it's the other way around in terms of what is most likely to be effective. So self-management and what pain services do outside of the pure kind of medicine side of things isn't this desperation option when medication has failed or not worked, which is actually the norm in most people. It's actually the gold standard treatment, right? And this is the reverse to how things often happen in the community. And understandably, this can be really confusing and really frustrating for patients because we try and make sense of how people are telling us, you know, this is what you need. And the normal responses are, if someone suggests, if you don't know how this stuff works, that you need to see a psychologist, that can be interpreted as, well, it's kind of all in your head. It's kind of a mental health problem. If they're suggesting you need to see physio, it might be, oh, they think I need to be stronger, or OT, they think I need equipment, right? So it's really important to help people understand that this is not just something that people get cast off to when medicines don't work. The collection of these various clinicians is actually the most evidence-based thing for helping people live enjoyable lives where they can do the most stuff they want to do, even despite having persisting pain. And so this is a slide that I lifted from, conveniently, a similar presentation I did for, I think, the MS Society a few years back, maybe 2021. Because one of the main questions we got is, okay, what are the differences though? What might the differences be in working with chronic pain between people who have MS and people who don't? So the similarities are that regardless of what type of pain you have, the focus is on independence. It's based on a biopsychosocial framework. It's based on this idea that we know that these therapies change the pain system and how the brain and body work. And the kind of core things we look at are the same. Learning about pain, helping people to move and exercise, manage psychological aspects of pain, help socialize, etc. Some of the differences might be that there might be increased focus on working with aids, assistive technologies, and social supports, more liaison between treating specialists, being a bit more careful about the limits of people's physical abilities, some more specific stuff to manage related symptoms like swelling, cramping, spasms, and then kind of thinking about how actually the strategies people are using over time may need to be changed a bit. So instead of this being specific treatment for a diagnosis, the best evidence is specific treatment for the person, that it kind of looks at these same domains, I guess, across the board, no matter who is being seen. And so I'm a clinical psychologist, and I get to ask people fantastic questions about, before they saw me, what did they think? when someone said maybe you could benefit from going to see a psychologist. And often people will be anxious about seeing a psychologist. They might be worried that someone might be sneakily suggesting they have a mental health problem. But psychology input does not mean that pain is all in your head or a mental health problem. Having psychology input or a similar type of input is a really normal part for lots of physical health conditions that have an influence on quality of life, right? If someone said to you, I've got a diagnosis of cancer and I've been offered psychology support, it would be odd to say, oh, are they trying to say your cancer is in your head? The goal of psychology and of other non-medical therapies in general is not to reduce pain. Sometimes it is a side effect of doing these therapies, but as a thing to aim for, it usually isn't that effective. What we're looking at helping people with is other areas that we know are related to pain. And we usually find that actually people can make really significant progress in how pain affects their life, even if their pain stays relatively static. And you can't separate psychology from pain. This is one and the same. This is part of the same system. So for every single person, there is a back and forwards between how psychological factors affect the experience of pain and vice versa. It would be really nice to feel like we can kind of take those apart and just treat one of them, but unfortunately that isn't the case. Bear with me while I check the time. So just very briefly, some of the most common psychological therapies that are encountered in the context of pain management. One of them might be familiar, so it's called cognitive behavioral therapy, or CBT. This is one of the most widely used psychological therapies. And again, not necessarily across psychological disorders. It is used to help people who suffer from a wide variety of things, including medical diagnoses. It has the largest evidence base for treating pain and pain-related problems. And it is based on the premise that as humans, it is really normal for us to have automatic thoughts about ourselves, about other people, about the world around us, but that sometimes these predictions can be inaccurate and actually unhelpful to us. So CBT aims to help people to understand how these things work, identify some of these patterns, and develop strategies to kind of challenge some of those things that might be getting in the way of their life. So on that little image there, that's the very basic model, that if something happens to you as a person, you have thoughts about this because your brain has to make sense of it in some way. Depending on what those thoughts are, that is going to lead to a particular emotional response. And then based on that emotion, you're going to act a certain way. So an example of how this might work in practice, if someone comes to me and says, look, you know, I'm faced with the idea of going out with my friends, but my immediate thought is, oh my goodness, I'm going to be such a burden to them because of my pain, because I have to go slower. It's going to be really annoying to them. That makes me feel sad. The emotion I have is maybe some shame, some guilt. And then because I feel that, I sort of like, oh, maybe, no, I'm not going to go out. I'm not going to socialize. So I lose something really valuable. And so what that might look like in terms of psychology work is helping to challenge that prediction, helping to look at the evidence for the fact that you are, going to be a burden to your friends. They're not going to want to hang out with you because chances are they actually probably like seeing you. They're probably your friend for a reason. And if they know that you're managing something like this, they might actually like to support you and try and facilitate some social engagement. But those thoughts and the emotional processes can be a really strong driver of actually what we end up doing and not doing. Another really common one is this thing called acceptance and commitment therapy, which is less about kind of challenging aspects of thinking and emotions, but more about making space for living alongside pain. So it's helping people to focus on the stuff that's important to them and trying to enhance their ability to not get as stuck in unhelpful and unpleasant emotions or behaviors, and be able to better divert their attention to doing stuff that makes them feel good, that kind of fulfills their values and gives them meaning. And usually when we work with people, we kind of give them a bit of an idea of how both of these things work, and we often let them choose. We say, look, one of them involves you doing lots of challenging of thinking. One of them does much less of that. It's more about how we can help you to get kind of unstuck from some things that might be unhelpful for you and help you focus on the stuff in life that's actually meaningful. So there you go. There's a 100 km/h summary of a few things that might be interesting, and I hope there'll be some comments, and I'm more than happy to try and clarify and explain some of those things. So thanks.
Thank you so much, Simon. It's yeah, very, very interesting. Everything, it seems quite revealing and quite difficult to achieve, you know, in some respects. And people are asking because self-education is so important, you know, and this psychological approach to pain. Can you recommend us any books or scientific reviews or even online pain self-management, I don't know, courses that you think,
Yeah,
because
there's
at the
a
end
book that
it's
we
all about
there's a book we give out or loan out as one of the programs we run at Burwood called Manage Your Pain. I think it's by Mike Nicholas. John will correct me if I'm wrong. And so yeah, Manage Your Pain by Mike Nicholas, and that's a very scientifically sound and sensible and accessible kind of manual for people to be able to learn about pain and help treat their pain themselves. There is a pain management app, and I'm loath to recommend apps, but there is one called Curable, which I also don't like the name because it suggests that there is a cure when actually it's more about management. But aside from those points, it's actually a really good evidence-based app. We got access to it through work, just basically as a test run a couple of years ago to see if it was something that was good enough that we'd feel comfortable recommending to people. We don't get anything for that. It's more just giving people options when they don't have access. And it's pretty solid. It has some really nice educational features and some quite practical stuff around being able to manage flare-ups. So can say that that's pretty solid too. And there are a bunch of other options and plenty of quality stuff on YouTube and online as well. So there's Explain Pain is kind of a broad organization who make educational materials and books as well. So there is quite a lot. Sometimes it just takes some guidance from someone who's familiar with the material to make sure you're getting quality stuff. So sometimes that's where primary care or local pain services can be able to provide some quality stuff.
Would you be able to email some of these resources to me?
Yeah,
and
for sure.
can
I'll
share
have a chat to my colleagues next week as well, and perhaps I can email some stuff through to you, and you can pass that on to people.
Excellent. Thank you so much. And another question is, do you think all MS patients should be referred to?
I saw that question. I mean, I don't necessarily think that everyone should be, because I think that if you refer people to services that they're not ready for, you have the risk of ruining their likelihood of re-engaging in the future, right? So an example there is, if people are not ready for a pain service and not interested, we don't see them. We wait until later because we don't want to give them a crappy experience to begin with. So I think that it would be fantastic if people could be offered it. But I'm also aware that clinical psychologists are somewhat rare beasts, and there are maybe not enough of us around as people would like. But I think that it is definitely something that would be valuable to a lot of people, because there's a lot of things about adjustment to dealing with a new diagnosis, understanding it, the symptoms that come along with it as well. And again, those are not mental health issues. They are normal human issues with having to deal with something which is life-changing. So, oh yeah, I'll always endorse psychology.
And another question is, do you see a correlation between exercise and pain management?
Yeah, I guess I can answer that in one of two ways. So exercise is something that does have pretty reasonable-ish evidence in helping people in kind of more general sense. We know that bodies and brains like movement and activity, and if they don't move and if they're not active, then sometimes they can be more protective and create more pain. But this is where kind of having expertise is really important. And so we rely very heavily on our physiotherapists in our service, because unlike other kind of more acute physiotherapy that's around strengthening and things like that, pain management physiotherapy is more about finding how people can do a consistent amount of exercise without completely pushing themselves and crashing, and then having a miserable time, but also doing enough that their brains and bodies are benefiting from it. So people who can exercise consistently tend to do much better, but people who try really, really hard to push themselves often do worse because they will have these big periods of crashing.
Can I just say something on exercise? Thanks, Simon.
And
that's great.
One last question. Yeah, sure.
Okay. The two things about the exercise. One is, as Simon said, there's actually good evidence that exercise is useful for chronic pain. That's one aspect. But the next aspect is this, that people have to be, just like Simon said, it's no good telling people that they're going to get better from psychology. Now they've been to 4 sessions of psychology and they've still got pain, so psychology has failed. That's a ridiculous notion. So similarly, the aim of physiotherapy in chronic pain is not to recover from pain, but to remain active despite the pain, to keep your life going and your fitness levels up despite the pain. So people sometimes say, well, I've been to physio and I've still got the pain. It failed. That totally misses the point of physiotherapy. And as with clinical psychology, as Simon mentioned, it's not the aim of physiotherapy to reduce pain, but sometimes an outcome of that is that the pain reduces. If fitness levels go up, they get more enjoyment from their life, the body functions better, maybe the pain reduces. So really important not to think that physiotherapy, activity, exercise is a cure for chronic pain. It is not, but it helps you to manage it.
Thank you so much. Thank you so much. Yeah, it's been really, really revealing and really interesting. And people are going to review your presentation and the slides. Of course. Thank you. Thank you so much for tonight. It's amazing.
And thank you again from me to both of you for speaking on pain management and MS. As you both said, there is so much, and I know that was just the tip of the iceberg, but I think really there is a lot for people there. So the recording will be available on our website, as well as the slides. So thank you both, John and Simon and Luminita, for tonight, for speaking to us all, for taking the time to share your incredible expertise. We're so lucky to have people like you here in New Zealand who can give us that kind of guidance. Thank you again, and good night to everybody.
Thanks. Good night, everyone. Bye-bye.
Yeah. Bye.